Hey everyone, and welcome back to the Contempo Coding live stream. I am excited to be here for another great Saturday. We're going to do some Q&A. There's definitely some hot news that has been going on in the industry that I'm sure you all want to know about. I've already been getting some questions, got some queued up that came through from the forum, seeing some coming in through the chat. So, hey, glad to be here. Really excited. We are 1 week away from Christmas. I can't even believe it. I got my green lights on. Yeah, getting a little bit festive in here. Great to see you all in here. So let's just go ahead and we can get started with the live stream. Good morning and greetings. Really excited to be here. So we're going to be talking about career paths, certifications, some medical coding questions. We're going to talk about classes. We're going to talk about goal setting for 2021, 2022 if you want. Hi to Marissa. Say hi to everyone in the chat. Nuala, good to see you here. Allie, great to have you along. So I want to start out with talking about our code books. Yeah, new code book, CPT 2022 goes into effect in just a few more days. Can't believe it. So if you haven't gotten your updated code books yet, or you don't have an application that's going to give you those updated codes, make sure that you're getting that information. It's coming up a lot. I think it's even was it one of my questions that came through about the code books? I know I saw it, even if it wasn't in the form, it was definitely on one of the comments of my videos. Let's see here. Yes. So the way that the Aapc works is once they've changed over the calendar year, they want you to use that calendar year's books. So starting January 1 of 2022, they'll want you to use the 2022 CPT, 2022 ICD-10-CM, 2022 HCPCS. You can still use the 2021 version, especially if you don't want to make that time investment to rewrite an extraordinary amount of notes that maybe you've written in your books, but you are still permitted to use the previous years. You'll just not have all those new code updates that will be in there. Yeah, so hey, Tracy, good to see you in here. All right. Yeah, I started just like a minute or two early today because I'm going to have to kick out a couple of minutes early because I'm going to do a presentation for one of the chapters in Hawaii. There are actually quite a few hours behind us. I think it's 10 a.m. their time, but it'll be 3 p.m. my time. Have a comment in here from Julie Ann Wilson. Julie Ann Wilson says, hi, good morning. I just received my certification in medical billing and coding. I found your videos are very informative. Thank you for helping. Absolutely. I'm glad I'm here to help you out. I found out that there's a lot of instructors and some fairly prestigious colleges that have been supplementing some of their courses and stuff with some of the videos on my channel, which is pretty cool, pretty awesome. Let's see, Ruiz, it's your first time watching. Well, great. I'm glad to have you here. I am shocked that I don't have more viewers in already with everyone asking about the exam changes that are happening for 2022. And that is one of the questions. So let's go through some of the questions that came through on the form. What have I got here? So it says, I'm new to every aspect of medical billing and coding, and just this week completed my first semester at Delco Community College, where I'm enrolled in the medical coding and billing certification program. My head is spinning with all of the abbreviations being thrown around. I was wondering if you could make a list of abbreviations that are represented on coding books, as well as the coding specialties. So what is a CPMA, CRC, E&M, CM, etc., as well as explaining what those certifications are good for. And I think that's a great idea. I think I do have some materials related to different certifications, specialty certifications, if some of those specialty certifications are worth it. But that would be an extensive list of abbreviations. I think it's something that could be done. I don't think it can be done right around this time because I have to update a lot of course curriculum and stuff with the code changes. But yeah, that's a great idea. And I'll definitely keep an eye out. And if anyone in the chat knows of any resources where there's like a list of just medical coding related abbreviations, definitely let us know because that would be something I think that would be beneficial to people when they hear terms like E&M and AWV. There's just, and I think that goes through with every industry, a lot of alphabet soup. So it also says, thank you. And I look forward to watching your Q&A, Rachel. Yeah. I hope Rachel made it on today. I have a question coming in from the chat. So Grave Wolfwood says, would it be worth if someone in their 40s with no transferable skills to jump in this career? Absolutely, I think so. I've known people in their 40s. I've known people in their 50s, in their 60s even, that have gotten into medical coding. I feel that, it has to be something that you have an interest in. It has to be something that you're willing to make that commitment to. It sometimes can be difficult to land your first coding job. That's probably one of the top complaints you'll hear about from people who got into medical billing and coding is that it can be difficult to find that first coding role. So you really, really have to be committed to it. If you're someone who goes in with the expectation that you're going to pass your CPC and then immediately get a job right away, you can be very, very disappointed if you find out that maybe it's a bad time for jobs in your area. And you have to have a lot of strategy as far as what your plan of attack is going to be for finding a job. So knowing where to apply, knowing how to get your resume updated, like on projectresume.net, knowing how to navigate to sites like codersdirect.com, how to link up with recruiters. So as long as you're committed that this is a career path you want to get into, you understand that there's going to be work involved, that there's going to be time commitment, cost commitment, that there's going to be a commitment as far as dedication into making sure that you get into the correct job, then I don't think the age gap will make too much of a difference. A lot of people these days actually are making that kind of midlife career change, right? There's a lot of people that go from teaching into IT, or people that are in IT going into, retail man. Like there's a lot of people that halfway through, that midlife area, they make a good career change. Question says, what would you suggest in getting if I work for a family physician office? I only verify insurance for the PCP office visits as of right now. Thank you for getting answer and channel. So are you saying that you're looking to getting into like a billing and coding certification and you work in a family physician office? Or are you suggesting that you are looking to transition from family physician into maybe a different type of specialty? What would you suggest getting if I work? So if you're talking about like as far as certifications go, I would say probably go for your CPC with the AAPC. There's a lot of opportunities that certification can bring you. So if you're looking for a good baseline, just kind of coding related certification, that's the one I would go to. Unless you exclusively want to get into billing, then there is the CPB certification through the AAPC. There's also the CRCR certification that's been very good with revenue cycle just in general. That's an excellent certification as well. We have here, I'm a respiratory therapist for greater than 30 years. Been through a coding program, just have to take the exam. Is billing a decent work from home endeavor until I'm certified with the CPC? I would say so. There's a lot of coders that do start out in the billing department, because of just how much money is on the line and how complex coding can be. There is some hesitancy, a little bit of reluctancy for organizations to want to hire coders that don't have a couple of years of coding experience. So oftentimes you can get a job in the billing department, and that will give you a lot of exposure. It might not have that title of coder, but you will be using codes, you will be getting familiar with codes, and then you can start to build up that expertise to transition into a higher coding role. Or you can just use that as a stepping stone. I've seen a lot of organizations, especially in the past couple of years, that once you get into the organization somewhere, even if it's scheduling, even if it is registration, even if it is, payment posting, that they're reducing a lot of the times in which they will allow you to transfer. I've seen some as little as like 3 months you have to be there, and they will allow you to transfer to another department, permitting that you've asked your manager and that they've said that it's okay to do so. But that was a good question. So I have a question here. Can you point out the recent changes in the online CPC exams? And you said you have a CPC exam scheduled in March. Sure, I can definitely cover that. Hold on one second. Yeah, so if you haven't seen, there was an email that came out from the Aapc exam department. It was on the 16th around maybe around midday. And it stated that they will be changing the time of the Aapc exams starting January 1. So January 1, instead of the examinations for the Aapc being typically 5 hours and 40 minutes for most exams like the CPC, it's going to be reduced down to 40 minutes for the exams. Most of them will have 100 questions instead of 150. The ones that did have more, I believe 200 questions, will now go down to 135 questions. So actually, I have the email here. So if you break that down, so a 5 hour and 40-minute exam would be 340 minutes. So with 150 questions, you would have 2.26 minutes approximately per question. Now that it's reduced to 240 minutes, 4 hours, and 100 questions, you actually have a little bit more time per question, just a couple of seconds more, but it's 2.4. So 2.26 to 2.4 per question. And they did link a white paper that they have that they did a lot of this wasn't like a quick decision that the Aapc made. It was a very ooh, there we go. Where's my stuff coming? It was a very well-researched, tested decision that they made. So we can actually take a look. I think I have the white paper up here somewhere. Let's see. Here we go. I can show it to you guys. So this is the white paper that the Aapc published in relationship to some of the changes that are going on with the exam. It's only 15 pages long if you're interested in reading it. But there were it basically details the psychology behind the exam, how much thought went into, is the reduction of the time and questions going to have the same kind of outcomes as a longer exam with more questions? So it went through a lot of rigorous testing. It went through a lot of beta testers through local chapters. I'm not sure if they did. I would have to assume that they did it online as well. But some parts that I found interesting, and let me kind of zoom this in, is that basically all that's really changing is the time and the amount of questions. The complexity of the exam is not changing. The sections of the exam aren't changing. They compared it to a lot of national benchmarks in other industries. They did psychometric analysis. So again, this was not just We just want to shorten this to cut some corners. This was very well thought out, very well researched. If you're interested in learning more about any other specifics, the AAPC is actually having a live stream on their AAPC Facebook page on Wednesday the 22nd at 1 p.m. Eastern Standard Time, which is 11 Mountain Time. And that will be the time that AAPC Alex and a lot of the representatives of the AAPC, like Ray, are going to be talking about the changes and answering questions. So if you have questions, definitely make sure that you mark that time to be on the social hour on the 22nd that they're going to be conducting to discuss some of those changes. But let's get back to the white paper. So it basically talks about how the same outcomes were found once they reduced the time and the number of questions. And I think they basically said that, I can't remember exactly where it is, but in here it does state that when they looked at the data of the people who did the 5-hour, 40-minute exam and compared it to the 4-hour, 100 question, like the outcomes of pass fails were only like minimally changed by 1%. So the outcomes are basically the same. I know a lot of people have been asking about, for example, well, how many questions are they going to ask for med term? How many questions are they going to ask for surgery, etc.? So like if we look at the AAPC website right now, under the certification breakdown for the CPC, we can see it still gives us the current breakdown. So it still gives us the questions, like it says, the 10,000 series in surgery, there will be 10 questions. So there are basically 17 different sections currently in the CPC exam, if you count, the 10,000, 20,000, et cetera, et cetera. So 17 sections times 3 would be about 51 questions, so 17 sections. If we took 3 questions off of each section, it would be 51 questions. So my assumption is, since we're going from like 150 to 100 questions for the CPC exam, and they're keeping the structure the same, like it's, again, just the amount of questions and the time is being shortened, it would make sense that probably each section of the exam will have maybe 2 to 4 less questions, kind of depending on if it's a bigger chunk, if it's a lesser chunk. Again, they haven't published that information yet, but that to me kind of seems like it would be a logical assumption, that they would just kind of take the existing structure and chop a couple of questions off each one. So, medterm, I think, is a smaller one. Is that the one where they do eight questions? HCPCS is 5 questions. So like maybe since HCPCS is really only 5 questions, they might still keep HCPCS at 5 questions, or they might reduce it down to like 4 questions. But I think the Facebook Live is probably the best bet if you have questions about what the breakdown is going to be. So Amit's asking kind of about the benefits of the new rules. That's a great question as well. Ooh, I didn't close the white paper, did I? Let's see where I have it. So one of the benefits, I think, is, first off, it's not going to be as time consuming to take the exam. The exam won't be easier. It's going to be exact same complexity. It's not like they rewrote the entire test bank. It's probably still going to be questions from the exact same test bank, same kind of mixture of levels of complexity of questions. But I think one of the points that they brought out here, which I think was fantastic, and let's see if I can find it. Let me do a quick Control F. So one of the interesting things here on the white paper that's noted is that the in-person examinations are administered by local chapters. And what it basically says here in the white paper is, the people that are proctoring for the exams, they typically show up a half hour before the exam starts. They sit there for the entire exam. Then they have to stay afterwards a little bit and make sure everything's packed up. Then they have to go to the post office. So it's really more a 7-hour kind of time commitment, basically almost your entire weekend, usually like a Saturday is usually when they have the exam. So, there's a lot less people who have the capacity these days because of just how busy our lifestyles are getting to take that amount of time and volunteer for it. So when we shorten the exam 2 to 4 hours, it opens up a lot more opportunity. More people are willing to say, oh, I can sit and volunteer for 4 hours to proctor the exam. The other thing that I like about this change is that I feel that a lot of um, a lot of proctor locations feel pressured to start very early in the morning so that they can kind of finish by early afternoon. I would be hopeful that because of it only being 4 hours now, instead of doing exams from 8 until what it would be 1:40 in the afternoon, that we could now maybe do examinations from like 12 to 4, or do examinations from, maybe have one in the evening and do it from 5 to 9. So having that shorter time does, I think, also allow a little bit more flexibility from the people who are scheduling exam locations to fit that into the day a little bit easier, right? So yeah, I think it's definitely a change from the positive. I think it's going to be better. You'll probably always have those people out there that are going to go, oh, well, that's not fair to me because I had to sit for the exam for 5 hours and 40 minutes and I had to do da 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 da. Um, and honestly, I think we should be more I think we should feel that the people who come after us should have it easier. I don't think it's a great attitude to be like, "Oh, well, I had it hard, so everyone should have it hard." I think if it's more accommodating, but still has that same complexity level, right? Then it's a great opportunity. I think it's a great positive change too. So for the online exam, from the information that's been put out, my understanding is it will be 2-hour chunks. And since it state that nothing really else was changing, my assumption is that it will still be you schedule those 2 2-hour pieces. So you can do one maybe in the morning, in the afternoon, or one on Saturday and one on Sunday. But of course, that information on details is going to come directly from the AAPC. This is all speculation from my point, just kind of my thought process of what might change. No, I definitely agree with you, Amy. I'm really hoping that we're able to start getting more locations. I know in my area in particular, we're still having trouble with some of the local hospitals allowing spaces because that's who we used to rely on. We used to rely on our local healthcare organizations to let us borrow a free conference room because the officers for that area happened to work for the local hospital. We did have I think we did have one hospital that was like, "Oh, well, you can use our space, but everyone has to wear their masks the entire time, and you can't have any food or drink." And with an examination time in 2021 of 5 hours and 40 minutes, to say, no, you can't have a drink for that period of time was a little bit, that was kind of like probably the breaking point. So it harder to find alternative areas that are also cost effective. And I think that could be another positive change with the shortened time. There are some very adventurous, very dedicated chapters that might say, well, now that there's a shorter time, what we'll do is we'll rent a space for the day and we'll have one exam from 8 until noon. And then maybe we'll have this break for lunch and have a second exam from 1 to 5 o'clock in the same space. And that I think would be probably more cost effective than having to rent the same room twice if you're having to rent a space that does cost. Yeah, so Amy, they've been working on that for a while, and now they've gotten, it's not an easy thing, I guess. They were pretty confident, it seemed like at the beginning of the year, that more of them were gonna go online, and, they test a lot of things. There's a lot of stuff that goes on behind the scenes that they don't talk about until it's kind of, like, ready to go. So, yeah, I can't really speculate on what other certifications are gonna go online now and when. I do think that is still something that they're in discussion of, but I'm not certain. I have also gotten questions about, a HEMA. Is there going to be any changes there? To the best of my knowledge, their examinations are the same. I think AHEMA certifications, and correct me if I'm wrong, someone, because I've not taken any AHEMA certifications, but they have historically, I believe, been shorter in time length than the AAPC exams, which I think may have been a partially contributing factor as well. A question here from Meg. Hi, Victoria. I'm from New York City, working in hospitality and wanting to start my new career in medical coding. I'm at 29 years old. Is it too late to start? Absolutely not. Oh, no, absolutely not. I think there's even some people here in the chat that started after 29. I started at maybe 25, I want to say, something around that. Yeah, 29 years old, definitely not too late to start. I would definitely make sure, though, that you have a good school in mind if you're going to research it. Like if you're debating between schools and you're like, I don't know about this community college, I don't know about this. I have a partnership with onlinedegree.com. You can look with them and they'll help pair you up with a good school, or you can just go directly through the AAPC. I've seen a lot of people lately in the comments of my videos saying, hey, I'm signing up for such and such college. It's going to be $19,000. It's going to be $30,000. That is an extraordinary amount of money to pay for medical billing and coding training. And that's one of the things I used to struggle with when I used to teach at a technical school. Is a lot of the healthcare students, even if they weren't medical billing coding students, had to take like an introduction to medical billing and medical coding. And those were, for example, medical assistants included in that. And one day they told me that they were paying like $30,000 in tuition for an associate's degree program in medical assisting. And my jaw hit the floor because at the time, medical assistants didn't even make $30,000 a year. So it's very difficult. Oh my gosh. But yeah, so if you're debating about schools, default to just going through the AAPC or an instructor that is licensed and approved through the AAPC. So they have like that credential designation. So this certificate, I think right up here, is the one that I have from the AAPC, that I went through training, passed an exam, and a approved instructor through the AAPC. So I would check with that. So don't spend $30,000 on medical billing and coding training. But yeah, I think it definitely is never too late. Let's see. Jasmine says, good morning. I really enjoy your YouTube videos and I apologize for the long paragraph. I've been coding for 5 years. I received my CCA back in 2020. I've coded for multiple specialties with a large hospital in my area. I'm finding that a lot of employers are not familiar with or don't want a CCA and prefer other credentials. I'm also in the space where I'm getting coder burnout, especially with the productivity requirements increasing every year. I want to get another credential, but I'm not sure. So, one of the difficulties with having an AHEMA credential is they don't have the breadth of specialty credentials like the AAPC has, right? Like the AAPC, you have professional coding, outpatient coding, inpatient coding, risk adjustment coding, and then all of the different surgical specialties, family medicine, etc. If you've been in this for 5 years and you've got your CCA, you could always just try for your CCS or CCSP. That might be a little bit better. But if you're getting burnt out, have you considered maybe getting into auditing or getting into something more like hands-on with providers, even in provider education, where instead of just sitting and coding and doing productivity coding, you're still looking at the codes, analyzing them, but doing more of a quality assurance type of role. I actually know a really cool coder in my area. Gosh, I should call her and schedule up supper or something, or have lunch with her sometime. But she has this really like awesome role where she just does like data analysis and develops coding edits. So, something you could do is even go into sites like Indeed.com and search for things like CPT or ICD-10-CM and see what other kind of job titles are coming up or out there. Look at, what are my thoughts about CRC, CDO, and CDEI? Um, I think I think there's definitely still productivity related facets of all of those. Probably not at the same pace as maybe some of the other types of coding out there. CRC is going to be a lot more looking at longer charts. Same thing with CDEO, CDEI. I think the main focus for those, though, yes, is going to be quality. I've had some auditing roles even in the past, and some quality roles where, yes, there's still some productivity standards, but not to the extent that there is for some of the other coding roles. I think the CDEI is still pretty new to comment on, how it's going to be intercepted and viewed and handled by some of the healthcare organizations out there, the recruiters. Sometimes it takes them a little while to kind of pick up on the new certifications. The CDEO has really gained some good momentum. When it first came out, I'm going to be honest with you, it was when the CDEO first came out, it was really during that phase where healthcare institutions only wanted to hire RNs for their documentation improvement. And thanks to the work of people just kind of advocating, like Brian Quee, and saying like, hey, there's a lot of people in health information that even though we don't do hands-on clinical work, we know the thought process behind the clinical work and the documentation and can work in CDI. Why are you just hiring RNs? And that really flipped the table on things. And now there are a lot more healthcare institutions that have backed off on that and said, yeah, we're looking to hire people who really know more of the coding, billing, documentation piece and understand the clinical piece from a more administrative type of position or thought process. So I think those are great credentials to look at. The CRC, I think, will probably still have a lot of that same mentality. It's a lot of looking at the charts and still a little bit more productivity based, just probably, just focusing on ICD-10-CM though. This is a great question. If you could go back in time, what coding would you tell your younger self to make the most money as the goal? If the goal was solely based off of finances, not about happiness, which is not my focus anymore. I'm like, well, having money does make me happy, but interventional radiology, I think, would be a great one to get into. That is, and I've had people come in and talk about this in the past about how that's one of the more elite certifications is that CERC credential, and that's one of the more specialized areas. So that when you are someone who knows interventional radiology or an interventional radiology coder, recruiters want to just like gobble you up. They basically have projects almost waiting for you. So it does tend to be a lot more profitable due to the complexity of that. And if you're interested in learning more about interventional radiology, definitely check out radrx.com. That is my friend Stacy, and she's amazing. Hold on. She literally wrote the book on interventional radiology coding. Let's see if it'll load up for me. Here we go. Yeah, so check out radrx.com. Let me move myself over here because you can't see the shop now button. But yeah, she has lots of great books, tools, education. So yeah, so if you want to get some information on interventional radiology, she's the girl that you want to get in touch with and get some of her training. And she does have a coupon for my viewers, Contempo 10. So if you purchase some of her IR, like cracking the IR code books and stuff, you can get a discount on them. But she's the girl to go to. I'm not familiar if you're talking. So confirm that the BCSC course name is now changed and the certification is no more available. That one I'm not even familiar with. I apologize, but yeah, that is not one that I want to that I'm not familiar with. Apologize. I just started losing my train of thought reading the comments. Yeah, this person says I took a 10-month online CPC course with UMA Ultimate Medical Coding Academy. That's 10 to 15K. It's a little pricey, but if they have a great program, that's fantastic. Taking a CPC test February 2022. Yeah, she's 59. It's never too old to start. My former mother-in-law started, I think, in her 50s as well. Let's take some more questions that came through from the form. What do we have here? Oh, this is a great question. Do you have any examples when a patient comes in for an annual wellness exam that turns into a regular office visit? How do I know when to change from coding a wellness exam instead code for an E&M office visit? So an annual wellness examination is often referred to by patients as their quote unquote free Medicare visit. And there's a lot of confusion around it in the industry in family medicine, in the Medicare patient population. So the annual Medicare visit is intended to be a survey to assess risks and goals of the patients. It's not a head to toe physical exam where they're checking your lungs and checking your reflexes and all kinds of stuff. They are really checking to make sure, like, are you able to feed yourself? Are you able to navigate around your home? Are you having any, or we're going to try and detect any sort of mental health issues? We're going to make sure that you're going to get, your colonoscopies and all that good screening stuff. So what happens a lot of times, though, is patients will come in for their free Medicare visit, because that's how it's kind of promoted to them. And they want to go, oh, well, I'm having all these problems. I have these chronic conditions. Can we manage this and this and this and this and this and this and this while we're here? Which really isn't the intent of the Medicare wellness exam. I wish there was a clear-cut kind of line that you could say, hey, this is this Medicare wellness visit. This is when a sick visit is. One of the situations that we're going to encounter with annual wellness visits is, since they're Medicare patients, almost all of them have some kind of chronic condition. A good amount of them are going to have hypertension or diabetes. They're going to have, high cholesterol. There's going to be something wrong with them. We're talking about a patient population that is 65 and older. The fact that they have chronic conditions alone doesn't mean that we can go, oh yeah, well, that's going to be an E&M and we're going to bill you separate. Even if it's something like refilling medication, like if they could have called in and gotten their naproxen refilled over the phone, does that really have a medical necessity to bill a whole other office visit for them? So, if they come in for the AWV though, and they say, oh, I'm not feeling well, I'm having congestion, cough, sore throat, my joints ache, et cetera, et cetera, et cetera. And we go, oh, you know what? Let's schedule your annual wellness visit another time and then bill for the sick visit. We want to take care of that now. Then in that case, I would say we should probably just bill the sick visit. Yeah, if it's an annual wellness visit and they also have a complaint like they're having pain in their knee, then I would say bill the AWV, make sure we have documentation describing exactly what we did for that acute problem, that knee problem, and handle that. So, where it gets a little gray can be when we have an annual wellness visit and then we're trying to manage the chronic conditions at the same time. Like, what is above and beyond that would warrant us to have a separately billable service? So oftentimes I say, it's good to have separate documentation, or if you have just one documentation and you cross out everything that's AWV related, like this is all the stuff that we're going to do in regards to our AWV, and we take a look at what's left, is that going to support the medical decision making to bill a level 3 service or bill a level 4 service? Can we warrant that? Is it something above and beyond just, oh yeah, you have rheumatoid arthritis and we refilled your medication? Was there still enough there to warrant an additional E&M service above and beyond the AWV? One thing I found very helpful for one of the organizations I worked for is to call our local Medicare contractor and say, hey, we're having a lot of questions about annual wellness visits, and ask if they can do targeted training and do a webinar for your organization just on the AWVs. And that's a good time then to ask some of those questions like, hey, we're having a scenario. Let's say we have an AWV and we have a patient who has a lot of chronic conditions, but it was planned ahead of time. Like, how would Medicare view that? So that, I think, is a great way to kind of handle some of those questions, just to take them directly to your Medicare contractor. Angela's saying, if you have your CPMA, is CRC needed? Absolutely not. So when we hear the credential CPMA is Certified Professional Medical Auditor. So that is actually auditing just for professional fee services. It's not auditing for risk adjustment. Risk adjustment is a different type of coding. So if we think about the different types of coding, we have professional fee coding, so coding for services that were rendered by clinical providers, billable clinical providers, physicians, nurse practitioners, PAs, etc. Then we have inpatient coding for the hospital facility. We have outpatient coding, so billing for outpatient facility services. And then we have risk adjustment, which is just ICD-10-CM diagnoses for those quality payment programs and risk adjustment models. So the CPMA, Certified Professional Medical Auditor, is auditing for professional fee services. So there really isn't a risk adjustment auditor credential. But yeah, so you don't need to have your CRC to be a CPMA. All of the credentials to the Aapc are kind of standalone. So you don't have to have credentials in any sort of order. You don't have to have one before the other, with the exception of there are some stringent rules in regards to what was formerly called the CPCI, but is now referred to as the Aapc Improved Instructor. That's the only one anymore that really has some different regulations in regards to it. So if we go to, let's see here, certifications. I'm not sure if is it still under certification? Let's see here. Resources. Become a certified instructor. That's the only credential with the Aapc that still has some strict requirements to it. So in order to be an instructor, you have to be an Aapc certified member in good standing. You have to have at least 5 years of medical coding experience. You have to complete the instructor course. And then the instructors that teach the CPC must hold a CPC certification. So you have to have, excuse me, you have to have the credential for whatever certifications you're going to be teaching classes for. So even though I have my approved instructor status with the Aapc, I can't teach the CIC credential because I don't have the CIC credential. What do you suggest we should give more attention to? CPT, ICD-10-CM, HCPCS, PCS, or medical terminology, or history of managed care to get good grades in the CPC final exam in 2022? So the CPC exam has no PCS coding. There's absolutely zero PCS questions on the CPC exam. I would focus mostly on CPT because that is the bulk of the examination. So if we look at the existing structure of the CPC exam, which I had pulled up a little bit earlier. So the exam breakdown, and for 2022, it's going to be the same. It's just going to be slightly less questions for each category. A lot of it you can see here is the 10,000 series, 20,000 series, CPT, E&M, which is also CPT, anesthesia, radiology, lab path, medicine. Med term's only going to be 8 questions for the rest of the year, probably a couple of less questions on med term next year, assuming we're just going to dock down everything a little less. Anatomy, 8 questions, ICD-10-CM, 10 questions. So the big bulk of the CPC exam historically has been CPT coding. So that would be more so the area you want to be familiar with for your exam. I am familiar with the AHIMA certifications. I don't have any AHIMA certifications, but I am familiar with the AHIMA certifications and some of the differences with the AAPC certifications, particularly that AHIMA has particular books that you are and are not permitted to use for certain exams. They have different structure as far as, AAPC goes by calendar year book. So January 1, we're going to test on 2022, and AHIMA, you can still test for 2022 for a few months afterwards. So I am familiar with the AHIMA examinations other than having not personally taken them. How many years of experience do you recommend before becoming CRC certified? You don't need any. Honest to God, you don't. I've known lots of people that just have their CRC certification. There are people who have gone from their CRC, new from other industries. There are a lot of people who have it as a second or third credential. They had their CPC, 5, 6, 7 years ago. Now they're going to get their CRC. There are no requirements to take your CRC. You don't have to have X amount of years of experience. You don't have to have a certain degree. There's a lot of people I've known that are getting into their CRC now that used to do nursing. And I think that's an excellent transition if you really like the ICD-10-CM coding. So that's been a great transition for them. But yeah, if you even look on the AAPC website under the CRC, as far as what the requirements are, it definitely makes it easier if you have a lot of ICD-10-CM experience. But let's see what it says. So if we go to certification requirements for the CRC exam on the AAPC website, it says they recommend having an associate's degree. That recommend does not mean you have to. You have to pay your exam fee and you have to maintain membership with the AAPC. They recommend that you have at least 2 years of experience in risk adjustment or a risk adjustment coding course. Justin is asking, do you know if you pass a certification test, either the CPC or CCS, how long it takes for you to get the certificate from them that you passed? It's usually not long, a couple of weeks. As far as getting the paper certifications, one thing I can tell you in regards to, if an employer asks you, if you need they need to validate that you passed your CPC or your CCS. They can do that on the AAPC and AHIMA websites. So with AAPC, you can just give them either your member ID number or the email address that you have registered with AAPC, and they can actually look it up on the AAPC website. And I can show you, because for some reason for me, it doesn't work in Google Chrome, but it does in Microsoft Edge. So let's see here. I'll bring it up in Edge then. So if a recruiter has your member ID number for the AAPC, what they can do is here at the very bottom of the website, there's this little credential verification that they can use. So if they have your member ID and your last name or your email address and your last name, they can hit this verify now, and it will give them the information about if you did pass your CPC or whatever credentials you have, the date that you passed them. And I'm not sure if it gives... Not sure. I don't think it gives your renewal information. I think it just gives your active credentials. It depends on when you would want to test, Muriel. So if you're going to test in 2022, you would probably need the 2022 coding books. You can still get away with using the 2021, but there have been some changes. I don't think there's a ton of ICD-10-CM changes from 21 to 22 that are really going to impact the CRC exam. That is one of the things I do have to look at a little bit later. Probably, I don't know if I'm going to get to it at the end of this month, maybe next. What is risk adjustment and where do these coders work? So risk adjustment is the process of analyzing and aggregating costs and expected costs of patients using ICD-10-CM coding. So we can recognize healthcare trends and costs by categorizing different ICD-10-CM codes into groups. So, for example, we might have what we call an HCC, a hierarchical condition category, a group of codes that we know have a related expenditure. They cost about the same. So maybe like lung cancer or cervical cancer, different types of cancer. We go, oh, these patients usually cost us X amount of dollars a year, and that's all the same. We'll group it into the same category. Excuse me one second. So the risk adjustment coders are really focused on looking at diagnosis codes because we can recognize that, a upper respiratory infection isn't going to cost us as much as a patient who has congestive heart failure. So they're really rooting out those high expensive cost diagnoses because there's more reimbursement now attached to them. There's a lot of quality payment programs that are being developed by commercial insurances, that are being developed by Medicare, that they'll say, hey, we'll give you extra money if you take care of these really sick, costly patients with all these different ICD-10-CM codes that we've kind of categorized and grouped together in these cost categories, because we know they're going to cost more. And if you do a really good job taking care of them, and we know that they're supposed to cost us more, but you keep the cost down, you keep them out of the hospital, which is going to be very expensive, we'll give you some extra bonuses. They might increase physician fee schedules. They might give them a quarterly bonus for some of these different quality payment programs. So based off of that, there's a lot more focus now on diagnosis coding than there has been in the past. It used to be that you went to your physician office, and if they did a great job, they did a bad job, they still got that same fee for service. But now there's a lot more payment tied to outcomes and severity of diseases. Oh, Rashid says, thanks for all your past tutorials. I just passed my exam. How long would it take to get my certificate? Probably not too long. If you're within the United States, usually it's a couple of weeks. I'm not sure about some of the other countries in which we have the credentials available. Test changes for 2022. If I took classes for the CPMA, but if I take the test in 22, would I need to use the 2022 books and get them ready for the test, or will they let me use 2021? They will let you use 2021. The test does get updated, but basically the changes from one year to the next are typically pretty minimal. It's not like they're like, oh, well, it's a new year, we're going to rewrite the entire curriculum. They basically review the existing curriculum, go, is there something that needs to change because maybe a code changed, and they'll tweak that. Or they'll go, okay, this information now Medicare does something different from this year to the previous year. We're going to change that. They're not going to rewrite the entire curriculum from year to year to year to year to year. They're just going to only change those little bits, or maybe there's some new information that they have to throw in a paragraph or two. As an approved instructor, I get usually the curriculums for now a few years. And when I look at one curriculum for 1 year, I compare it to the new stuff that's coming out. And we're talking like, maybe there's a 5% change in materials, including all of the practice questions, paragraphs, everything, from year to year. So it's not a lot. It really is not a lot. It's very minimal changes. But yeah, you can still use your 2021 books in 2022, but just understand that there's going to be probably, some code changes that might be on the exam. But you have to weigh that between, like, do you want to rewrite all of your notes in your book versus do you want to take that little bit of a risk that maybe there's an updated code question that you won't be able to look up the code for because you're using your 2021 books. Anyway, I am so sorry, but I have to skedaddle. I have a presentation coming up in 8 minutes that I have to get ready for the Hawaii chapter. So sorry to cut it short a little bit today, but I am going to be Christmas Day is in 1 week, Victoria. I'm going to see if I can maybe swing this on Friday of next week. Keep an eye out to YouTube, to LinkedIn, to Facebook, and see what time. I might switch it over to Friday if I can do it. If not, I will see you guys the following week. Have a great week. Have a great holiday. Really excited to have you guys joining me. Great videos coming up next week. I will see you guys soon. And until then, just keep on coding on.